Well, welcome everyone. Jeff, thank you for that kind introduction. And as you mentioned, tonight's seminar is really going to be on the surgical treatment options that are available to us in pediatric hydrocephalus. And it's kind of a practical talk, if you will, lots of video and some descriptions of some procedures. So looking forward to presenting this. As Jeff said, I'm an attending at Lurie Children's in Chicago. I have no disclosures related to this subject matter. The only thing I would disclose is that I am on vacation this week in a socially distanced way. So looking forward to getting back to the beach tomorrow morning. So I just wanted to just kind of tip my hat again to Mark for setting this lecture up, because he did a very nice job in really providing the foundation for a lot of what I'm going to talk about. So with regards to the CSF physiology, pathophysiology, circulation, and then in terms of hydrocephalus, the incidence, the classification schemes, the clinical findings, imaging, and just a brief introduction into some of the surgical procedures. So I'm not going to touch on much of that except perhaps the etiologies that we'll see. But, you know, when you talk to parents about hydrocephalus or even other surgeons, they oftentimes are criticized because, you know, shunts frequently malfunction and it can be a very difficult problem to treat. You know, it seems to be a very simple problem when you think about it. Fluid builds up and we have to just treat it, drain it, and take care of the problem, but it's really not that simple. Hydrocephalus essentially is a disorder of CSF physiology, and it results in the increase in the intraventricular pressure, which leads to accumulation of CSF within the ventricles, and it's frequently associated with elevated intracranial pressure. It's most often because of an inability of the brain or our bodies to reabsorb the CSF that's being produced. In rare circumstances where there may be hypersecretion related to a chorioplexus papilloma or a chorioplexus hyperplasia, then you may have an overproduction of CSF, but generally it's because of a failure of absorption of the CSF that's being created. We know that without treatment, a lot of secondary phenomenon can occur. It can lead to neurovascular damage and inflammation of the brain, as well as additional tissue injury. The cortical mantle becomes thinned and stretched out. This damages the ependema of the ventricle and leads to accumulation of metabolites in the subependymal zone. And it can also damage the neurons. And if you look at autopsies of hydrocephalic brains, there's fewer synaptic connections, and there's just a general less richness of the dendrites in the neurons themselves. And all of this contributes to just further compromise in their neurological development. So this is really something that's critical to treat. I just wanted to touch on the etiology because it's really important in terms of deciding what type of surgery might be appropriate for an individual patient. And the table on the right is from a publication a few years ago from the Lancet, talking about the different types of hydrocephalus. And generally it's the way that people often describe this or break it down is into congenital and acquired varieties. And some of the more common congenital varieties are those like primary aqueductal stenosis, a tumor that's present in a newborn or a young infant, intrauterine infections like cytomegalovirus, genetic disorders like the L1-CAM, the L1 cell adhesion molecule disorder, or X-linked hydrocephalus, and then Chiari malformations, whether those associated with the Chiari-2 malformation or even Chiari-1 malformations can sometimes lead to development of hydrocephalus. Most of those are Chiari-2 malformations. And then there's other acquired forms related to infections, hemorrhage, intraventricular or subarachnoid hemorrhages, and also tumors. So just some of the more common ones. But I think from a practical point of view, it's really important to understand the difference between a communicating and non-communicating hydrocephalus. As Mark mentioned, all hydrocephalus is obstructive. At some level, there's an obstruction to the either flow or absorption of CSF. But the distinction between communicating and non-communicating is important because it helps us decide which may be the best type of treatment. So in a non-communicating hydrocephalus, as in these two upper pictures here, you can see a young boy 15-year-old boy with a tectal tumor and acute hydrocephalus. There's clearly obstruction to the passage of CSF through the cerebral aqueduct and leading into the classic triventricular pattern of hydrocephalus and elevated intracranial pressure. So up until that moment in time where this boy finally closed off his aqueduct, his CSF circulation was fairly normal. Other types of malformations like essentially congenital stenosis or other other things where the foraminal outlets of the fourth ventricle may not be formed can also be, fall into this category. The communicating types are known for their extraventricular obstructions. So somewhere, either at the subarachnoid space, venous sinus interface, there's an inability for the CSF to be absorbed. So that's seen in infections or hemorrhages, and then in children with skull base abnormalities where they can have venous hypertension, an occlusion of or narrowing or stenosis leading to venous hypertension, which makes it very difficult for the CSF to be reabsorbed. But the classic is a child like this here who actually was operated on last Friday, who newborn with a very large head and evidence on the susceptibility imaging of prior hemorrhage in utero and acute non-communicating, communicating hydrocephalus, where everything is open here, and the CSF is just not absorbed. So in terms of deciding who to treat, it's in some cases it's very simple. If the child has large ventricles and clear signs of elevated pressure, then the decision is usually obvious. They need some type of CSF diversion. But a lot of kids have large ventricles and they may be relatively asymptomatic. You'll see a child that may be macrocephalic and their ventricles may be moderately enlarged, and then those without symptoms, and those ones are the difficult ones to think about. And there's very little direction in the literature. So most neurosurgeons, if in this day and age, if they have an asymptomatic child who's developmentally normal with mild to moderate degrees of ventriculomegaly, will watch that very closely at times, but watch that for any symptoms to develop before plunging in and trying to treat. But there may be a bias towards treatment in younger kids, and kids less than 6 months of age in the same scenario, who can be very difficult to properly evaluate in terms of their developmental function or neurological progress. So it's important to recognize, though, that really there's no long-term non-surgical treatment for hydrocephalus. Diuretics have been tried, but they're really marginally, if at all, effective, and they're really not recommended for children with hydrocephalus. So once the decision has been made to intervene, then the treatment options really are based upon the etiology. So what's the cause of the hydrocephalus? What's the patient age? That has important implications. And what, if any, are the associated comorbidities? And it really comes down to, do we shunt this child, or is there some endoscopic solution to their hydrocephalus? I just want to spend a minute on some of the history because it's fascinating, but it also kind of gets you to kind of where we are today in terms of how we are in this current state. So some of the earliest endoscopic attempts or treatment attempts for hydrocephalus are over 100 years old. You can see the first one of the first reported attempts was in 1910, where Victor Darwin Lespinasse essentially fulgurated the choroid plexus with an endoscope in a child. Dandy did the same thing. His first 4 cases, 3 of the kids died almost immediately after surgery, but he went back and did the 4th case, and the child survived long term. So he used the nasal speculum, you can see there in this drawing, made a couple of burr holes, and essentially pulled the choroid plexus out of the child's brain. And even when we inadvertently make contact with the choroid plexus, sometimes it can be fun to stop some of the bleeding, and you can imagine what that must have been like in that day and age. The first endoscopic third ventriculostomy was performed by Mixter using a cystoscope and kind of with transmitted light down from an external source. And Putnam reported like 9 or 10 cases of choroid plexus cauterization in 1934, and then about 10 years later, he reported another 20 or so cases. So there were clearly attempts to treat hydrocephalus endoscopically very early in the last century. But all this changed around 1950 when Nelson and Spitz at CHOP kind of introduced the concept of the modern shunt, and essentially they developed a valve. It was like a spring ball type of valve that worked well. It was typically introduced into the heart, into the right atrium, but it had a lot of problems. The peritoneal, the catheters, the cytoelastic materials were not really up to the task, and it was difficult to keep them open. But that eventually improved. And then the big step was the Holter valve. When John Holter, whose son actually had hydrocephalus from monomeningocele and actually passed away from when he had a shunt malfunction, he was a machinist and developed a one-way valve that was attached to the valve that Nelson and Spitz developed. And essentially that changed everything. And the effectiveness of shunts really improved a lot. And with the newer technology, surgeons were able to place them into the peritoneum with much lower complication rates, and the surgery itself was technically easier. So that's really when the enthusiasm for endoscopic procedures started to wane. So I want to concentrate today on 3 areas of treatment. First, very briefly, is the treatment of some of the smallest infants that we care for, those with post-hemorrhagic hydrocephalus of prematurity. Just a few slides on that. Most of the talk is going to be on endoscopic third ventriculostomy with a few examples of cases, the indications, the preparation of the patient, the procedure, and then some pearls and pitfalls. And the same for shunting procedures for hydrocephalus. Primarily, they'll concentrate just on the Ventriculo-Peritoneal shunt, which is by far and away the most common of all of these. So we know that germinal matrix hemorrhage is an important problem for pediatric neurosurgeons. Fortunately, the incidence seems to be decreasing with better pulmonary care, better critical care of these very fragile infants. But about 30 to 50% of children with severe germinal matrix hemorrhage will develop a ventricular enlargement. And some of those will go on to develop post-hemorrhagic hydrocephalus. It requires diversion. The problem is when this happens, they're oftentimes very small. They can be 700, 800, 900 grams, way too small to accept a ventriculo-peritoneal shunt. So in many of those cases, temporary measures might be required in the smallest of these infants. So the timing and when to intervene and how we intervene remains controversial. There's a wide range of practice patterns that guidelines are really not very clear on this, and the determination to treat is really based on the clinical signs of the infant. If they're symptomatic, sometimes they may exhibit bradycardia or apnea. They can have progressive ventricular enlargement and then other signs of raised intracranial pressure. So usually that's when the surgeon may deem it necessary to intervene. And again, there's some temporary measures, but really none of these are recommended in this day and age. So Diamox was used in the past, but really not recommended at this point. Carbonic anhydrase inhibitor. Frequent lumbar punctures, again, was used in the past, but they can be very problematic and very ineffective is the bottom line. So they're really very rarely, if ever, used. Direct ventricular puncture sometimes can be used to sample CSF if there's no way to get CSF in other manner, but the problem with that is it leaves a mark. It can leave a significant tract porencephaly. So that's really been abandoned for routine use. And an external ventricular drain in a very small infant like this can also be very problematic in terms of just managing that because of keeping track of how much CSF is draining and also the high risk of infection. So most of these temporary measures have been abandoned on this left side of the slide. What it comes down to really are a few other options. And one of those is a ventricular access device. And you can see there's an actual image of one there with a coin. So they're very tiny devices. Essentially, it's like a reservoir and catheter joint. There's different variations of that. Different manufacturers have different versions of that with different sizes. But essentially, it's placed into the ventricle and the subcutaneous reservoir is there, and it can be accessed periodically as needed for control of the ventriculomegaly. And usually in the best of cases, the ventricles stabilize. It's rare to see them get much smaller. You can only tap these so many or so often. Any more than once or twice a day can be really difficult or problematic on the skin. But at least stabilize things until the point where the child may become of sufficient size to accept a shunt if that's deemed necessary. And another option is a subgaleal shunt or a ventriculo-subgaleal shunt. And this is a picture from a colleague, but essentially it's the same type of device, but it's kind of left open on the side or the bottom, and the device is placed into the ventricle, but a large subgaleal pocket is created. This is a piece of like silastic attached to it with a few sutures to keep the galea or the scalp from contacting and then adhering to the underlying soft tissues and closing off that space. So the fluid, as you can see, collects underneath the scalp, and it can be unsightly, but essentially it's kind of a more continuous drainage of the CSF into the subgaleal space, and it's absorbed that way as opposed to having to tap the shunt or tap the reservoir on a daily basis. So just another option for young infants. Eventually, the decision needs to be made if the child the device will need to be converted to a ventriculo-peritoneal shunt or some other more definitive surgical treatment. So that's really all I wanted to say on some of these very young infants that may require surgery. You'll probably see these on a rotation from time to time, depending on which service you're rotating on as a student. So I want to shift gears now to some endoscopic procedures, really the endoscopic third ventriculostomy and its role in pediatric hydrocephalus. So this is really a great way to deal with non-communicating hydrocephalus. And as we'll see, the indications are beginning to expand more into some of the communicating types of hydrocephalus. But essentially, the procedure itself creates a new pathway between the ventricular compartment and the subarachnoid space. And you can see here, typically, the CSF is generated in the lateral and third ventricle, and even in the fourth ventricle, but the majority is up above in the lateral and third ventricles. And it flows down through the cerebral aqueduct and eventually exits into the subarachnoid spaces through the foramina of Magendie and Luschka in the posterior fossa. And you can see the CSF is in the subarachnoid space, making its way up towards the vertex where it'll eventually be reabsorbed. The key here is that in somebody who has a blockage, either at the level of the midbrain, posterior third ventricle, fourth ventricle, or the fourth ventricular outflow foramina, the CSF can't get out into the subarachnoid space. So the CSF, just a very simple concept, is allowed to escape through an opening through the floor of the third ventricle. So a third ventricle ostomy. So we make a small fenestration or ostomy in the bottom of in the floor of the third ventricle. Really, success of that procedure depends upon the appropriate doing it on the right patient. So there's certain categories we know that there's a very high likelihood of success. So children with problems in the third ventricle, specifically the posterior third ventricle. So if they have a pineal region tumor, like this child here with an immature teratoma, very high success rate for an ETV in that situation. If there's an issue with the aqueduct, whether it's a congenital aqueductal stenosis or if there's a tectal tumor, as in this child here on the bottom left, you can see here, again, another very good case where there's a very high likelihood of success if the surgeon is able to accomplish a third ventriculostomy. And then there's some fourth ventricle problems. So here's a severe Chiari malformation where the fourth ventricular outflow foramina are just obstructed because of a lack of space. It can also be seen in Chiari-2 malformations, posterior fossa tumors. Even after resection, say a child with a medulloblastoma develops hydrocephalus, they can typically be good candidates. Many of those kids for a third ventriculostomy after the fact or after the tumor's removed. And rare, but another possible case is a child with a cerebellar infarction with a lot of cerebellar edema and hydrocephalus because of that. And one other thing is that we know that the success of these procedures is generally better in children over 6 months of age, probably because of the subarachnoid spaces just aren't as well developed in those younger kids. So there's a lot of anatomical considerations that one needs to pay attention to. So both of the ventricles themselves and the surrounding structures. And here's a 10-year-old girl who had as we'll see in a few minutes, a large thalamic tumor that was causing obstruction of the aqueduct. So important things that we need to look at before considering surgery is, where is the basilar artery, and is there really enough space for us to safely perform a third ventriculostomy? Here's the target right here. This is the tuber cinerarium here. So we want to make sure that there's enough space here to safely pass our stylet or whatever device we're going to use to make the fenestration without endangering the basilar artery. So that's an important thing to look at. So if it's very close, or if it's up against or in contact with the dorsum or with the clivus, then that may be a relative contraindication. In kids that have Chiari-2 malformation and spina bifida, if they have a very large massa intermedia, which they oftentimes do, almost all of them do, but if it's very large, that may actually obstruct the ability to see the floor of the third ventricle. And then sometimes there can be tumors that there may be like a child with a germ cell tumor in the posterior third ventricle where there's some secondary lesion near the floor of the third ventricle. And just, even if you could do the third ventriculostomy, the tumor could potentially grow back and eventually obstruct the orifice of the third ventriculostomy. So things like that need to be considered. And another thing that's important in terms of anatomy and planning is the trajectory. And we'll see why this is an important point here, because I think an important message is that it's not often just a standard burr hole like you would use for an external ventricular drain or even a right frontal ventricular peritoneal shunt, because sometimes that may be too far forward and it may jeopardize the success of the procedure. So what I like to do on these preoperative images, and oftentimes right on the navigational planning station, is essentially draw the trajectory. And I find that where the tuber cinereum is, where the opening is going to be created, where the fenestration will be made. Here's the foramen right here. Here's the fornix, but you can see and just get an idea of where that burr hole should be. You can see the coronal sutures right here on this MRI. It may be difficult to see, but this is essentially how I plan this out on my planning station with the navigation, just to give you an idea, because if you put the burr hole a little too far forward up here, and you come in with your endoscope, then number one, your trajectory is actually towards the basilar artery, and number two, then if you really want to move anterior to look at where the anterior part of the third ventricle, then you have to put some pressure on the fornix, which can cause damage to that important structure. So just, it's an important thing. It's just not a stab in the dark. It really takes some planning to really pick out a proper entry point. When the surgery is performed, obviously the patient's in a supine position. Most surgeons prefer a right-sided approach unless there's a reason not to, say something on the right side. The head's a little bit elevated. I like a horseshoe, but some people can do that on a donut. And I prefer navigation for these, even in kids that have large ventricles for reasons that I just mentioned, but also, you know, the piloid sheath introducer that we're placing for the endoscope is oftentimes, well, it's usually 12 French, which is a little smaller than number 2 pencil. And, you know, you figure that's a big catheter to be placing into some young kid's brain. And it's nice to get that right the first time, because there have been a few cases where I've seen where the trajectory is off, and when you put the scope in, you realize you're on the opposite side, and that's not a good place to be. So it's an important thing. That's why I like to use the navigation, even with big ventricles, to optimize your trajectory, and again, just get that right the first time. So this is what I'm talking about. This is actually from a recent publication from Operative Neurosurgery, but this is a standard, you know, precoronal burr hole for an EVD or a right frontal shunt, Coker's point, but this may not be ideal, just to kind of, in many cases it'll work, but it may not be optimal. Another thing is 3 centimeters may be a little far from the midline, because again, the third ventriculostomy is a midline procedure, and if you come way lateral on your burr hole, then your stylet is directed towards the contralateral side, so you can potentially jeopardize the contralateral third nerve when you're making your fenestration. So I like to try to be a little closer to the midline when I do an ETV, rather than like a standard precoronal burr hole for a shunt. Again, registration. Another important thing here is comfort. Okay, you want to have your imaging, your navigation, your cameras, you know, your optics all kind of right in front of you. You don't want to have to turn your head to the side while you're working. It's kind of like playing a video game. You got your controller in your hand, but you're looking straight ahead at the TV. That's kind of the way I like to think of this. It's you want to be looking, you want to have, you know, a nice comfortable stance, have all your equipment right there ready for you. And typically it's done with 2 surgeons, one to hold the scope. If you don't have that, then there are scope holders that will hold the device in place, but most of the time we do these with 2 surgeons, one to secure and hold the scope in place and steer the scope, while the other one performs the instrumentation, the actual fenestration. And I prefer a curvilinear incision. In some cases, particularly in kids with tumors, we'll place a reservoir. Not always. The linear incision puts your burr hole oftentimes directly underneath the incision. So I think in my experience, it's been a little more likely to leak than with the curvilinear incision, but it's not a guarantee that it couldn't. So before the procedure, you need to really be careful and check all of your equipment, make sure it's operational. You don't want to put the endoscope in first and realize that something's wrong with it. So my preference is to pretty much do a dry run. We make sure all the equipment is working. We make sure the images are all focused and oriented properly, so that you know, there's no doubt that we're looking at things correctly. We typically have an irrigation system in place just with gravity. My preference is lactated ringers, but other balanced solutions are also acceptable. And there's some artificial CSF that's available as well to try to mimic CSF as much as possible. And again, all the instrumentation needs to be checked and organized before the procedure. And that's why I generally like to do a dry run with the resident or fellow and even the nurses. We have all the equipment laid out in the order that we expect to use it, make sure it's functional. So there's no waiting for something while you have the scope inside the third ventricle. So the steps really are that's what we're going to go through right now. But First is to enter the lateral ventricle. You can see the size of this peel away sheath here. We put the stylet for navigation right down the stylet so we can track that in real time, as you'll see. Once we're in the ventricle, with that, the scope is then passed down and we confirm. The first thing we do is confirm that we're on the correct side, the right side. And that's done by identifying the structures on the medial side of the ventricle, the choroid plexus and the septal vein. And then you can see the structures on the lateral side, so the thalamus-striate vein, and eventually the choroid plexus, which will take you right to the foramen. But usually, with the technique I described, you're coming right down on the foramen of Monroe. It's very direct and very straight. Again, care should be taken if you're too far forward. That anterior wall of the foramen is formed by the column of the fornix. So once we're in the ventricle, this is really an important picture, and this is what you want to see. So we're on the right side because the septal vein here is medial. Here's the choroid plexus. This is the thalamus-striate vein heading posterolaterally. And you can see the foramen of Monroe, partially obscured by the choroid plexus. And here's the column of the fornix here. So if our burr hole is really forward, and you have to put the scope in here and kind of torque that a little bit, you can wind up with some trauma to the fornix when you're done. And the choroid plexus then continues down into the roof of the third ventricle, along with these two veins coalesce to form the internal cerebral vein underneath in the third ventricle. So important, this is an important picture to recognize and to remember, just for orientation, for any type of lateral ventricle surgery, endoscopic surgery, even open surgery. So once we're finished with the lateral ventricle, we're just making sure we enter the third ventricle, we just go right down to the floor and inspect the floor, and we need to identify the mammillary bodies. They usually jump right out. You can see them very nicely. Here's the optic chiasm more anteriorly. The supraoptic recess is cut off here on this image, but you can see this pink structure here. That's the infundibular recess. It's pink because that's where the portal venous blood is kind of running down towards the pituitary gland from the hypothalamus, so it has that kind of engorged kind of pink appearance to it. This is the target point, the tuber cinereum right here. So in the midline, here's the tuber cinereum. You can see the thin floor, the third ventricle is thin enough that you can actually see the basilar apex here and probably the communicating segment, the PCOM coming in to join right here. But here's the basilar apex right here in the midline. So this is the target point. This is where we're going to create our fenestration anterior to the mammillary bodies, generally just behind the infundibular recess in the midline. Once that's completed, once it's opened, usually with a blunt probe or some other type of instrument, then we dilate the opening with a modified embolectomy balloon, and then we inspect the prepontine cistern on the bottom here. This is a grasping forceps that I like to use because it has a blunt tip. It's kept closed and we put through the floor. It's not sharp. I never use power. I think most people have gotten away to using any type of applied energy to make the opening because of the risks to the structures, and particularly the basilar artery in that area. So I just wanted to take it through a case here. This is a child that just had surgery about a little over a month ago for her hydrocephalus, but she initially presented 2 years ago with headaches, nausea and vomiting, and neck pain. Her parents took her to a local hospital, but by the time she was imaged and transferred to our facility, she was lethargic with bradycardia. And a colleague of mine took her to surgery for a placement of an external ventricular drain. She woke up immediately and felt a whole lot better. Her exam only was notable for papilledema. She had normal motor findings, no other cranial neuropathy. So you can see here she had this this large thalamic mass that was obstructing the aqueduct. We eventually performed an occipital transtentorial approach and subtotally resected the lesion. Most of it out, but not all of it. And it was unfortunately a H3K27M high-grade diffuse midline glioma. And she's battled that for the last few years with radiation, chemotherapy, and a few different clinical trials. But she returned recently with headaches and vomiting. And this is the progression from January to March until now in May. And she was having frequent headaches and vomiting. And you can see that here's the picture here on the T1 on the right. The tumor is growing back and it's now obstructing the cerebral aqueduct. So we recommended an endoscopic third ventriculostomy. Her oncologist wanted additional tissue like they always do. So we also were able to use a flexible scope to biopsy some of the tumor for additional material. But the primary goal of surgery, the first thing that we did was the third ventriculostomy to deal with her hydrocephalus. And just going to take you through this. So this is how, again, after the setup that I described, this is a right frontal approach here. And the resident's going to make the burr hole here in a second. And then once the dura is coagulated and open, this is the stylet here from this navigation system in the peel-away sheath. And you can see this video here, we're tracking real time through the brain into the ventricle to get us into the frontal horn the right way the first time. So that's you know, see a little drop of CSF starting to come out. We're just barely in the ventricle here. So that's how it starts. The obturator is removed, the peel-away sheath is open a little bit, and then the scope is introduced. Sorry, scope is introduced, and this is kind of what we saw immediately. So again, we want to make sure that we're on the correct side. She's got a very large thalamus striate vein, choroid plexus, foramen Monroe. The septal vein is really diminutive. Didn't really see it very well, but it's just not really there. But we knew we were on the correct side, and you can see here that we're going to enter the third ventricle here in a second, and really it's apparent very quickly. You can see the mammillary bodies right here as we get things stabilized. Here's the floor, the tuber cinerarium, infundibular recess, that pink color right here, the optic chiasm, the suprachiasmatic reflex. And here's, we're just looking back posteriorly to get a look at the tumor there that we'll biopsy in a few minutes, but this was just a quick look back there to see what it looked like. So this was a flexible scope, which you can take a look back. This can also be done with a rigid scope, but again, it can be difficult depending on where your burr hole is. And some surgeons have actually used 2 burr holes to do that, 2 different trajectories to biopsy and also do the ETV. So the flexible scope gives you some added options there. So again, here's the tuber cinerarium. There's the probe coming down, the blunt probe, the grasping forceps. You'll see a pop. Actually, you can usually feel that, but you'll see it too, that kind of floor shudders. A little bit of smoke there, just a small bit of blood from the surface, but that's really not much to worry about. That'll oftentimes stop with irrigation, which is kind of running slowly in the background. And then sometimes if it's really going, you may have to use cautery for that, but it's pretty infrequent to do that, or even tamponade that with the embolectomy balloon. Here's the balloon coming down, so you can see it pops through the floor, and we're just going to dilate this up here 1 second, and then lower the balloon again before we remove it. And there's a nice opening in the floor, but there's another membrane here that we got to deal with. So this is membrane umbilicus. You can see that in the way there. I think without, I mean, there's some smaller openings, but we generally recommend opening that as well. So I used a Bugley wire without power, just as an electric cautery wire, but it's a little stiffer than the balloon, and just made another opening, which we further dilated just to ensure that we had really a nice free opening to the prepontine cistern, as you'll see here in a second. And that's the ultimate view there, the prepontine cistern with the basilar artery pumping away the clivus here, and you can see the neurovascular structures off to the side. So here's the surface of the pons right here. And then when we're done here, I don't show the biopsy, but we kind of take a quick look when we're finished with the irrigation off, and you can see the floor kind of pulsating nicely back and forth with the cardiac cycle. Just gives you a good idea. So that's generally a good sign that things will work. So most of these children will go home on the post-op day 1 or 2. She did very well, was discharged the next day. Her headaches and vomiting resolved very quickly, and this was 4 weeks later. So you can see there has been a considerable reduction in the size of her ventricles, which correlates with her improved symptoms. Unfortunately, she still has a battle ahead of her with her tumor, but her hydrocephalus for right now is not a part of that. So other post-operative considerations: number 1, imaging. You know, some get that. I typically get a CT scan usually the night just to make sure, but not always, just to make sure there's no bleeding. But typically, when we're finished, we inspect the third ventricle and the lateral ventricle, and if it looks pretty quiet, then I'll oftentimes skip that. Need to watch urine output. You are making some manipulation of the hypothalamus. It's rare, but they can have some transient diabetes insipidus. Permanent endocrinopathy is very unusual. Antibiotics are continued for like a day. Some surgeons use dexamethasone to try to limit inflammation around the ostomy for a few days to let that kind of prevent it from sticking, if you will. And again, most kids are discharged home the next day or day after. Complications are pretty rare. Infection is very low, less than 2%. Hemorrhage, again, is also uncommon. It usually stops with irrigation or tamponade. But significant bleeding, if it happens, can be cauterized. But if not, then the procedure generally would be abandoned and an EVD placed just for external drainage. The thing we worry about the most, which is fortunately very infrequent, is an injury to the basilar artery. So less than 0.2%, and a permanent endocrinopathy, as I mentioned, is pretty infrequent. So in terms of outcomes, if you look at all comers, the failure rate at 2 years is about 35%, but most of those happen within 6 months of surgery, and success really depends on a few factors. Age is critical, and also the etiology. And this was really an important paper that was published in 2009 describing the ETV success score. And it's a very simple thing. This is something that you should, on a neurosurgery service, keep in your hip pocket, if you will, or take a picture of it and keep it on your phone. But it takes into account the age, etiology, and whether or not the person had a prior shunt or not. And you can see, just essentially simply add up the points. So in a 15-year-old boy like this with a tectal mass, never had a shunt before, he gets 50 points for being 15 years old. He's got aqueductal stenosis, that's 30 points. And since he never had a shunt, add that all up, that's a 90% chance of success. So it's a very high likelihood that that would work, as long as the other anatomic features, like technically you could do this, as long as the prepontine cistern is sufficient. It's not dangerous to try that. It's not contraindicated. And this score has been validated by other groups, and it really is a helpful adjunct to predicting responses. So generally, for less than 6 months, the results are not as good. At least 50% of those kids under 6 months of age will fail. And certain etiologies like myelomeningocele, there's a history of infection, or intraventricular hemorrhage, again, are much less likely to work. But in conjunction with choroid plexus coagulation, these generally may have a better outcome. And again, the best case scenario is a kid with a tectal tumor, a pineal tumor, or aqueductal stenosis, where up until the point in time when the things finally closed off, their circulation of CSF was normal. So if you can restore that circulation into the subarachnoid space, then it generally will work. So if you're over 2, the failure rate's pretty low. If it does fail, you can repeat that, and it can be successful in more than 50% of the cases. And late failures can occur. This is not this is a child that died of another coach had a tumor, but died of oncological issues a few years after ETV. But this was the autopsy. You can still see that the ostomy was open at the time of her demise. So again, ETV is really an effective treatment for hydrocephalus. It's important that you must identify the relevant anatomy before proceeding, and keep in mind that it's a deep procedure. You have an instrument deep inside the brain, so small movements and a gentle touch is necessary, because you really don't want to be whipping that scope around inside the head. And this is another patient. It's the choroid plexus, you can see nicely. You need to maintain control of that endoscope at all times, and you don't want to be advancing instruments beyond your field of view. So if the instruments, you can't really have that in there if you can't see the tip. Again, if there's a small prepontine cistern, or if the anatomy is otherwise distorted, then it may not be a good case. And this is just I'm going to go through this quickly, but you can see the tuber cinerarium here very nicely, the infundibular recess. Here's the floor, and eventually, once that fenestration is created, get a nice view of the prepontine cistern there. Basilar artery, we're just a little bit off to his left side. So that's ETV. So shifting gears briefly, and we'll just kind of come home with this, but this is the last part, is on the treatment of hydrocephalus with ventriculo-peritoneal shunts. Generally, ventricular shunts work for most people. There are some that seem to have a lot of problem with those, but the most common types of shunts that we use divert CSF from the ventricle to another body cavity where it can be reabsorbed, whether that's the peritoneum in most cases, the right atrium in others, the right atrium of the heart, sometimes the pleural cavity, and very infrequently the gallbladder, as I listed here. The peritoneum is the most common because it's very well tolerated. Technically, it's very easy for the most part, unless someone's had multiple abdominal procedures. And the CSF there just mixes with the peritoneal fluid, and it gets absorbed by osmotic diffusion through the capillaries. And some of that also goes way through the lymphatic system. So just it's handled like normal CSF, normal peritoneal fluid. Shunts are generally made of either a silastic material or polyethylene, and there's typically 3 components at its most basic level, most basic way of thinking of it. There's a proximal catheter, there's a valve, and then there's a distal catheter to convey the CSF down to the receptacle of choice. And this is a standard ventricular catheter. You can see the small holes. The outside diameter is about 2.5 millimeters. These small holes are very small. There's different configuration of holes that people come up with, but this is a fairly standard version. This is a type of programmable valve we'll talk about in a second. This is a fixed pressure valve. Different manufacturers have different options. Essentially, the valves can be either a fixed pressure valve. When the pressure goes above a certain level, the valve opens. When the pressure falls, it closes. It can also be a programmable valve where it works in the same way, except that it has several different settings. So depending on what setting you have, it'll open and close at variable pressures. A flow regulating valve tries to maintain a constant rate of CSF flow, irrespective of what the pressure is inside, just to kind of minimize, just to keep the CSF drainage more physiologic. And in many cases now, these devices are paired with anti-siphon or gravitational assist devices to try to prevent over drainage when somebody stands upright. And then the distal catheter you can see here, which will convey the fluid down to another body cavity. These are just two examples from two different manufacturers of programmable shunts. And you can see, depending on the setting, the opening pressure will vary from low to a higher level. And here's another version with 7 different settings, and including the 8th setting, which is classified as a virtual off. So if you put it up to the 8th setting, it just about shuts the valve off. Not completely, but almost. So kind of gives you several valves in one. So if you're not sure which pressure valve may work best for your patient, then sometimes we'll use these. But the truth be told, most people have, we don't have to often change these settings very frequently unless it's a very young child with small, very large ventricles, where you may want to kind of start very high and kind of gradually decrease that, or vice versa, gradually increase it if they're over draining too much. So that's really just a little bit on programmable shunts. Most shunts are placed on the right side. The goal is to try to get the catheter in the frontal horn away from the choroid plexus, so anterior to the choroid plexus. Again, I'll refer you to this article. There's a lot of important stuff in here in terms of the craniometry of different access points for ventricular catheters, just published a few months ago. But some surgeons prefer a frontal approach. Some people prefer an occipital approach. Others, with Fraser's point, it's more of a parietal approach to the atrium. And there's been studies to look at this, but really, in terms of outcomes, one is not any greater than the other in terms of the longevity of the shunt or the risk of shunt obstruction. So different options to consider. And here's a case. So sometimes we can also use an endoscope in shunt surgery. This was a recent revision we did. This is an endoscope that goes actually inside. We converted this kid who had a subdural shunt, which after he had a choroid plexus papilloma resected, we had to convert that to a ventricular shunt. But the point is that we're trying to get this catheter up into the frontal horn. We try to get it to stay up here because I was concerned if we put it in manually, it might wind up to the other side, or might even go into the temporal horn, which were quite large. And you can see on this image here, we're in the ventricle here. So my resident driving the scope, and this is the atrium here, looking down towards the front up here. And here's the temporal horn right down here. So we eventually kind of changed direction, went up towards the frontal horn, and situated that right up near the ependymon there in the frontal horn, just to try to get it as far away from the choroid plexus as possible, since that's a frequent cause of shunt obstruction. So when we're placing a shunt, again, supine, obviously, head is turned almost all the way to the other side, the contralateral side. It's important to put some type of padding or a bolster underneath the shoulders, because you really want to extend the head, because we like to think of it as you want to have the mastoid and the clavicle on a very flat plane, because if it's really kind of sinks down a lot, it can be very difficult to tunnel in that direction. So when we bring the tunnel, we want to tunnel the shunt and go from the head to the peritoneum or vice versa. We want that to be as straight a line as possible. The entire planned path of the shunt is included into the prep here. This is just some preliminary cleaning and draping out, but incisions are marked. We clip some hair as needed, not much, as little as possible, and then antibiotics are started. Generally, once things are prepped and covered, we open up all incisions. I prefer a frontal entry site, again, usually about 1 centimeter anterior to the coronal suture, but some thought needs to be put into that when you're working with a little infant, because those distances are much smaller than, say, in an adult. Again, maybe not as lateral in a newborn than say in a 10 or 12-year-old child. The peritoneum is usually entered through a mini laparotomy, but other options are a split trocar, and in people that have multiple abdominal surgeries in the past, or if they're obese, then a laparoscopic assisted is oftentimes very helpful. And I prefer to make a skip incision, so to go from the frontal region down to the abdomen in one pass, which can be done. I prefer a little skip incision here to help you tunnel that. It also keeps it a little bit further away from there. I've seen some older kids come back where the shunt is very close to the ear, and it can be very painful when they sleep at night or lie on that. So I like to get that shunt a little further back with a skip incision. In terms of getting it there, that's one of my least favorite things to do in neurosurgery. In an infant, it's generally not a big deal, but an older kid, teenager, it can be, it's the nuchal fascia, just getting through the neck can take a lot of effort, particularly in somebody who's had multiple shunt revisions. I prefer to go from the top down. A couple of friends and colleagues go from the bottom up. They both work. Somebody told me once, it's just when you're doing this, think of all the ways you could potentially kill somebody and tunneling them, because when you're coming from the bottom here, if you get into the chest, obviously that's a big problem. When you're getting around the clavicle, if you're under the clavicle, God forbid, there's a lot of important vascular structures under there you could deal with. And as you're coming up, you know, the sutures, the cranial sutures can be open in a small infant. So there's lots of ways you can inflict harm if you're not careful. Most of the resistance occurs in the neck here. And I usually put a Metzen bomb down there just to open that up and just bluntly just to push it through. It's a little more controlled than this device, but you can see a lot of times they'll begin to desaturate. If, you know, these babies have and this is important too, just to avoid the breast blood when you're tunneling so you don't mess with that. But you can imagine how hard it can be to ventilate the baby when they got this rigid rod kind of running from their head down to their abdominal cavity. So once that thing is tunneled, the distal catheter is passed down through this sheath here, and then the valve is attached, put into the system. And then the last thing I like to do is the ventricular catheter, small dural opening, as small as possible, to try to form a little bit of a gasket if possible around the catheter. And that's placed into the ventricle, and then trimmed to the right size and secured to the valve. Once you confirm that the CSF is dripping through the whole system, then you can place the distal portion into the abdomen and then begin closing. So in some cases, navigation may be helpful. It's an option. Endoscopic is an option, as I indicated in this example just a few minutes ago. And sometimes in a newborn, some people use ultrasound to help place that catheter. So here's just a quick example. This is a child from about a year ago who presented at term with a very large head transfer from another facility. And at 24 weeks, he had a fetal ultrasound that showed cerebral ventriculomegaly, but his parents did not want to undergo any additional testing. So they continued. The pregnancy was otherwise uneventful. He was delivered at term by cesarean section and transferred to our facility. His OFC was 50 centimeters. You can see where that falls on his growth chart here. His fontanelle was rounded and full. You can see just a large degree of cephalocranial disproportion. His head, the vault, is so much bigger than the face. And this was before we got started here. We took a spare cable from one of the endoscopes and hooked it up to a headlamp, and you can see when we dim the lights, the severe degree of hydrocephalus with the transillumination of the CSF through the scalp. His exam was otherwise unremarkable. This was his imaging, so you can see this clearly malformed cerebrum, a very thin mantle posteriorly. In these cases, I prefer to put a frontal shunt in if I'm going to put a shunt in, because there's a little bit of a gasket. It doesn't make a great seal around the catheter, but at least there's some tissue, as opposed to back here where there's very little, and you can wind up with the CSF ulma around the ventricular catheter. Here's an important thing, though. So in terms of deciding what type of treatment, you know, what are the options here? So a shunt obviously is an option. But in terms of third ventriculostomy, he clearly has aqueductal stenosis. His fourth ventricle is tiny. But look at his prepontine cistern. It's almost non-existent. And just because of the severe degree of ventriculomegaly, the brainstem is really pushed forward. So I think in my experience, it would be almost difficult to get an ETV in there. But he's also a newborn, so that also raises some concern. So in terms of his ETV success score, if you do the math, it's 40%. So he's a month old, no points. He's got aqueductal stenosis, 30 points. and no prior shunt, 10 points. So 40%. But I think, you know, again, most kids, it's about a 50% failure rate in kids under 60 or 6 months of age. So I don't think that this is, this should be 10 points here, sorry. 0 points for that, sorry, 30 points and 10 points for no previous shunt. So in combination with his age and this anatomic concern about the prepontine cistern, we placed a ventriculo-peritoneal shunt. It's possible that in the future, if he came back and malfunctioned, we could consider an ETV at that time. This was the surgery here. That's just, again, the preliminary prep before we covered him up. But here's my skip incision here to get it down to the abdominal cavity and the right frontal shunt. This is his scan, probably about 11 months of age. He came into the ER for suspected malfunction, which was okay. Here's his imaging. So you can see the shunt traveling down and then large amount of catheter within the peritoneum. Here's his growth chart, so he's doing well. He's clearly got some developmental issues, and he was later diagnosed with the L1 CAM hydrocephalus. So he has the gene mutation, so he has X-linked hydrocephalus, which is the cause of congenital hydrocephalus in about 10% of boys. And here's his scan. So again, significant cerebral dysgenesis, just an abnormal looking brain, but his hydrocephalus is well controlled. So the fun just starts for this guy though, because shunts, you know, obviously can have a potential lifelong problems, and there can be many long-term complications, which is a little different than ETVs. Most, fortunately, will occur within the first few months of putting them in. About 25 to 40%, depending on who you read, will fail within 2 years of placement. When they do, the symptoms are fairly characteristic: headache, vomiting, irritability, mental status changes, rapid head growth in an infant, and they usually require shunt revision for repair. And after that, the risk of shunt malfunction is about 4 to 5% per year. Typically, it's a proximal catheter that's obstructed about 3/4 of the time. And depending on the center and the series, the shunt infection rates vary between 2 and 9% per procedure, but most of those occur within 3 months. It's a problem because the whole shunt generally has to come out after some external drainage, and then a new shunt has to be put in, so it's a lot of morbidity with that. There's lots of other complications. Over drainage can lead to problems, subdurals, or even headaches. Under drainage, if it's not working well enough, if the shunt wasn't placed well, if it's not into the peritoneum, if you thought it was and it wasn't, it's not going to work. If it's not in a great spot in the ventricle, or if it's intraparenchymal, not good. The catheters can become obstructed. Typically, it's the ventricular catheter, but sometimes the valve or distal catheter in older shunts. And you can see here, they can also obstruct or break. I'm sorry, here's a woman, a teenage girl that had 3 or 4 disconnections for shunt. You can see the tip of the shunt hangs down just below the skull here. So when she moves her head a lot, eventually that just causes a weak spot there. And she, every 3 or 4 years, would break the catheter and have to have a new distal catheter placed. And the problem was her burr hole's so low here that it's hard to get a smaller valve down, a shorter valve, if you will. And some kids can have malabsorption. So shunts are common. They're much more common than endoscopic third ventriculostomy, but they are prone to both short-term and long-term complications. There's high failure rates and reoperations that can plague, the people with these shunts throughout life. Some newer technologies like anti-siphon devices and antibiotic impregnated catheters and programmable valves are widely available, but they don't seem to be making too much of a difference in terms of long-term outcomes. And the reason is that most of the most malfunctions are still related to occlusion of the proximal catheter, which has been a difficult thing to sort out or prevent. You take a standard shunt and put it in the laboratory in a beaker, it'd probably run for 100 years, but once you put it into a biological system, it really has problems. So last slide. Just while shunts remain a mainstay in the treatment of children with hydrocephalus, their design really has changed very little in the last 60 years since they were 60 or 70 years since they were developed. And while most kids will do well, there's still a potential lifetime of morbidity that's associated with shunt dependence and the complications associated with that. Endoscopic techniques, though, are now widely acceptable and are, have very high success rates with low morbidity. So the indications are expanding. So in some children with communicating hydrocephalus in conjunction with choroid plexus coagulation,
This is a new kind of reason for optimism in some of these kids, but it requires further study. And hopefully with further improvements in that regard and others, we can really decrease the number of children that are dependent upon these permanently implanted devices for the treatment of their hydrocephalus. So I think I'll stop there. Thank you.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.